You know that the name of fibromyalgia changed during the years, and once it was called fibrositis, and now it's fibromyalgia. But I thought that in the Holy Land, maybe the appropriate term for that is fibrodolorosa, because of the via dolorosa that this patient, unfortunately, are passing until diagnosis, the correct diagnosis, and treatment. I would like to thank Pedro. Where is Pedro? Okay. I would like to thank Pedro for inviting me to this wonderful place, Mallorca, Palma de Mallorca. We don't have, unfortunately, such beautiful seas in Beersheba. Beersheba is the southern part of Israel. It's a desert. But we have something in common with Mallorca, and this is the palm trees. So we have a lot of palm trees. And then we have something that is uncommon, I think, in Mallorca, and this is camels. We have a lot of camels there. Now, this is a kind of ugly camel you can see, and we are quite fortunate that in our lab, since we are doing genetic studies on pain, so we were able to produce a beautiful camel. Now, this is funny because I was looking for a nice picture of Paris for the EULAR that was held in Paris a couple of years ago. And every time I put the name Paris in the Google, he gave me pictures of Paris Hilton. I think it's quite offending for French people that Google thinks that Paris is Paris Hilton. Now, I would like to thank Pedro for something else, because this morning I learned finally the scientific basis for something that my mother was telling me many years, that if you have chronic pain, don't go to the casino. So now I know why. Now, the story of fibromyalgia is old. It's not a new disease. And actually, it started with this guy, Gowers, in 1904. At the time, it was called fibrositis because this guy thought that there is inflammation in fibromyalgia. During the years, we understood that there is no inflammatory basis for fibromyalgia. So in 1990, we changed the name to fibromyalgia. And these are the well-known 1990 ACR criteria for classification of fibromyalgia. And they are quite simple criteria. There are only two criteria, and you have to fulfill those criteria. One is the presence of chronic widespread pain for more than 3 months. And the other one, the presence of tenderness in these quite mysterious tender points. This is a set of 9 points symmetrically found from both sides of the body. So if you have 11 or more of these 18 tender points and you have chronic widespread pain, you can classify the patient as a fibromyalgia. This is the way that we palpate these points, and according to the ACR criteria, you should palpate these points with a force of 4 kilograms to elicit pain in these points. Now, this is quite simple. You can learn it in a very short time how to do this examination. However, there are situations in which it is more complicated to examine tender points. Okay. Now, fibromyalgia is not only pain. This is something that we should understand. Of course, the defining symptom of fibromyalgia is chronic pain, chronic widespread pain. But fibromyalgia is more than pain. Fibromyalgia actually is a constellation of symptoms, including sleep disturbances, fatigue, stiffness, and cognitive symptoms, and many others. And I put this slide. I understand that there are patients and also delegates of the local fibromyalgia association. And I've put this slide specifically for them, because there is still this unfortunate notion by some physicians that think that fibromyalgia is a psychiatric disease. And fibromyalgia is not a psychiatric disease. We heard these wonderful talks in the morning about what happens in the brain in fibromyalgia. And just to show you, the prevalence of major depression in fibromyalgia is only 20%. Only 20% of patients with fibromyalgia have major depression. And you can see, thank you, and you can see this slide, which shows you that the prevalence of fibromyalgia, of depression in fibromyalgia, is not different from other chronic pain situations like rheumatoid arthritis. So this is very important to convince the unconvinced physicians. Now, the SAR criteria were very important because they gave a homogeneity for collecting patients to studies, and it enhanced research in the field of fibromyalgia dramatically. But there was a sense of feeling that we are not very happy with these criteria, especially with the tender points. And indeed, during the years, we started to understand that there is some shifting in our understanding of fibromyalgia. We started here with the notion that fibromyalgia is a discrete illness of pain with focal areas of tenderness, the so-called tender points, and that all patients, or most of the patients, have psychological or behavioral factors. But during the years, we understood from studies that fibromyalgia is just part of a larger continuum of pain. If you want, it's the tip of the iceberg of pain, but it's not something distinct. And also that these patients have many somatic symptoms, and the tenderness is not a focal, it's actually diffuse in all the body, and psychological and behavioral factors are found only in some patients, but not in all patients with fibromyalgia. So there is a change in our understanding of what is fibromyalgia. This change has brought these new criteria that were introduced a year ago in May 2010, and I'm sure that we are going to discuss this criteria in our discussion here because I'm not happy with the criteria. I know that Manuel is not happy, and I'm sure that many of the rheumatologists are not happy with this criteria. This criteria, the big change between this criteria and the old criteria are that they omitted the tender points. So you don't need to examine the tender points in the new criteria, and actually you rely on the report of the patient on painful areas as well as on the severity of different symptoms. So in this criteria, you have 19 different areas, and you ask the patient in how many of these areas he feels pain in the last week, and then the score runs between 0 to 19. And then you have what they call the symptom severity score, which scores the severity of the symptoms from 0 to 3 of fatigue, waking unrefreshed, cognitive symptoms, and then considering somatic symptoms in general. And here, believe it or not, there are 42 different symptoms. Some of them are stupid symptoms that I never heard about, and you should tell how many of these symptoms you have, and then you have to decide whether it's little or moderate or severe stuff. Anyway, this symptom severity scale run from 0 to 12. And then by elaborate calculations of the scores of the widespread pain index and the symptom severity score, you can get these summations and decide whether the patient is diagnosed as having fibromyalgia. Now, fibromyalgia is not alone in the universe. Fibromyalgia is actually part of a spectrum of syndromes, which are called the functional somatic syndromes. And you can see that many of those sisters of fibromyalgia, like chronic fatigue syndrome, restless leg syndrome, PTSD, migraine, IBS, etc., actually overlap with fibromyalgia. By the way, in Israel, the organization of the patients of fibromyalgia is fibromyalgia and chronic fatigue syndrome. And I don't know if it's the same in Spain, because they realized that actually these patients have the same problems. So there is one unifying organization for both syndromes. And actually in the future, I think that if organizations of different syndromes will organize together, they will have much more power to compete with the governmental authorities. Now, the problem of fibromyalgia is this elephant. Patients with fibromyalgia goes with many symptoms, different symptoms to the physician. Every physician sees only his symptom. And you need the doctor here who sits here and see the whole elephant. And unfortunately, because of this phenomena, a patient with fibromyalgia, it takes to diagnose patients with fibromyalgia 3, 4, 5, 6 years after the beginning of the symptoms. And we should do something about that by training physicians. We have data on this, but if we'll have time in the discussion, we'll talk about it. Now, recently, Yunus have introduced a new term for these somatic symptoms, and he actually called them the central sensitivity syndromes, and that's because he thought that in the basis of these symptoms, there is one unifying pathogenic mechanism, central sensitization. Now, to complicate this story even more, fibromyalgia is not a homogeneous condition, and we have subgroups of fibromyalgia patients. So there are some attempts like this one from the group of Dan Clow in Michigan and others groups, and we are going to see more studies about subtypes of subgroups of fibromyalgia, and in the future we are going to see different treatments that are giving to different subgroups of fibromyalgia and trying to analyze the outcome of this. It reminds me in the old days what happened with lupus. For those who are rheumatologists, we started with lupus, and then we understood that lupus is actually a couple of different diseases under the same umbrella, and now we are treating lupus as subtypes of lupus and different types with different outcome. Now, what is the basis for pain in fibromyalgia? Actually, we heard a lot in the morning about the brain and fibromyalgia, and it's really all in your brain, but not like, you know, a physician tells a patient with fibromyalgia, it's all in your brain. He refers to that you are faking the symptoms, that you are a psychiatric patient, but it's really all in the brain, in mechanisms of the brain. And central sensitization has emerged as the leading pathogenesis model for fibromyalgia pain. Now, central sensitization, dorsal horn neurons become hyper-responsive to nociceptive and non-nociceptive somatic stimulation. This is the phenomena that is known as central sensitization, and it can lead to allodynia. And in central sensitization, we have, this is a condition in which we have CNS overreaction to pain. We have descending inhibition that is disrupted, and we have pain that is amplified in various brain areas. What are the clinical consequences of this phenomena, central sensitization? We have allodynia, which is formerly nocebo pain that becomes painful. We have hyperalgesia, that means that pain experiences are amplified. And we have secondary hyperalgesia, which means that there is spread of pain beyond the site of injury. And indeed, in fibromyalgia, there is evidence, a lot of evidence, that there is a disrupted balance of nociception. So we have increased pro-nociceptive factors and decreased anti-nociceptive factors. And here we have studies showing that there is decreased level of serotonin in the CSF. On the other hand, we have increased CSF substance P in fibromyalgia in different studies in different populations. We have also studies showing nerve growth factor that is increased in fibromyalgia. And we heard this morning about glutamate. We are going to hear more about glutamate. We have increased levels of glutamate within the CSF. And finally, a new study showing that there is increased plasma levels of brain-derived neurotrophic factor in patients with fibromyalgia. So there is a lot of transmitters, ongoing transmitters that are pro-nociceptives that are increased and decrease in serotonin in fibromyalgia. In fibromyalgia, we have also HPA axis dysregulation. There are millions of studies, but if I have to summarize all the studies, basically they say that there is a state of hypocortisolism in fibromyalgia.